This is SG2 Perspectives, a weekly conversation between the SG2 intelligence team and industry thought leaders about the biggest trends in healthcare. We're happy you joined us today. Enjoy the episode.
We found that ICU admissions increased 58% at non-children's hospitals and 30% at children's hospitals from 2019 to 2022. Tremendous demand on the ICU for a relatively common pediatric condition, but non-children's hospitals are divesting from ICU. They are not investing. They're not planning for growth in this area.
Welcome to SG2 Perspectives. I'm your host, Trevor Durin. Today we're talking about pediatrics, but we're talking more specifically about more than a handful of new insights we've found through a series of different data analyses we've done. Rhae Gamber from the SG2 team led much of that. We're especially excited to have Alyssa Harris and Hannah Murphy joining us from the Vizient Research, Analytics, and Insights team because they've led so much of this work and gone really deep on these topics. They'll publish articles in academic journals and stuff, so we're thrilled to have them join to talk about some of their findings as well. We'll cover a lot of ground today, a lot of nuggets, but it'll all be pediatrics focused. Rhae, kick us off. We're going to highlight several analyses and insights, mostly from Vizient's Clinical Data Base, the CDB. A lot of other CDB research we've published, especially in the last year or so, has been about the adult population. Why is it a great tool for peds research as well? And to talk about why you've asked so many questions of the clinical database lately.
Thanks for featuring this, Trevor. And I can't take the credit. Alyssa and Hannah have been using the clinical database to assess pediatric trends and find pediatric insights for a lot longer than I have. I've just gotten excited about all of the great data in the CDB to analyze pediatric trends. We often think of the CDB as an adult resource, and it is a pediatric resource as well. There's really a number of reasons why the CDB is a great tool for pediatric research. First and foremost is the sample size. There's a tremendous volume of pediatric discharges. It can be used to assess some of those high volume areas in pediatrics, like neonatology, like critical care. It's really great for analyzing those specific hospital sites that are important to children's hospitals, like emergency department, the NICU, and the PICU. Because there is such great volume, it's great for analyzing more low volume or niche diagnoses as well. To give you a sense, in 2024, the CDB had 1.3 million pediatric discharges, excluding normal newborns, and then an additional 750,000 normal newborn discharges. There's plenty of data to analyze. The other strength of the CDB for pediatric research in particular is the recency of the data. It updated monthly. The data is available to the hospitals that report into it only 1 quarter behind real time. And this is great for emerging trends, which we're hearing a lot about in pediatrics. Hannah can talk about her work in congenital syphilis, which is an area where we're seeing a lot of epidemiologic growth. We're talking a lot about infectious disease in pediatrics as well, measles, RSV. So we can quickly get on to those trends and see what's happening in the hospitals that are reporting in. Thirdly, the ability the CDB has to assess comorbidity and complexity. This is a core capability. Every encounter has the complete list of diagnosis and procedure codes. If you are familiar with the SG2's forecast, we rely heavily on the primary diagnosis code, which is great, but it doesn't tell us the full story of why a kid is hospitalized. The CDB allows us to understand all of the conditions that a child might be being treated for. And we've got a great study that looks at mental health in the pediatric diabetic population, which is a great example of that comorbidity and complexity analysis. And then the last thing I'd point to is the Vizient Vulnerability Index, which you can layer on all of the research that we do. Alyssa and Hannah have pioneered this, and I'll let Alyssa talk more about the VVI.
Thanks, Rhae. When it comes to the Vizient Vulnerability Index, or the VVI, it's something that we can layer onto research that we're already doing and change the way that we think about populations, pediatric, adult, and overall. The VVI is a community-level measure developed by Vizient specifically to capture a lot of different types of vulnerabilities, like structural and social, that can impact meaningfully a person's health and their life expectancy based on where they live. There are a lot of data sets that feed into it, but it's things like their socioeconomic status, housing, their ability to access transportation, education, environmental risk that impact their health before they ever even enter the healthcare system. One of the highlights of the VVI is that it is a free and publicly available tool, and it's also hyper-localized. You can get down to the patient zip code or census tract and attach the VVI at the patient level. And that makes it really usable for health systems to understand the risk in the communities that they serve, not just the risk that exists within their own walls. It is a great tool that can show how health is impacted by where people live. And when we look at how we apply it in research, in strategy, and anywhere in healthcare, we have found that when it comes to vulnerability, it's not evenly distributed across the healthcare system, across care settings. There's a much higher concentration of high vulnerability in, for example, children that present to the emergency department. And even when we take clinical severity and that looks similar when the patients come to the hospital, we see that children and adults from high vulnerability communities tend to present more frequently and they have worse outcomes. It is a cool tool that we can use to tell hospitals and inform health systems about risk and how to stratify risk that is not purely clinical risk. So if you're looking at things like capacity, prevention programs, community partnerships, it can be a tool that you can use to help identify where those upstream investments might impact and change downstream utilization. We like to use it in research to move beyond describing just outcomes and start to understand why things might be happening in certain populations in certain places. We've used it and applied it to pediatric research and pediatric data, and it's become clear that community vulnerability consistently shapes how and where children, pediatric patients are interacting with the healthcare system. One study that I applied that to is firearm injury. This is based on work that was presented at the Pediatric Academic Societies Conference, as well as in a blog post where we looked at pediatric firearm injury specifically in the emergency department. In the past few years, firearm injury has become the leading cause of death in children and teens, surpassing motor vehicle accidents. So a lot of the research that exists is on the prevention and safety side, but there's not as many studies that look at firearm injury through that healthcare lens. The emergency department is a really important healthcare setting because it's often the first, and it can be the only setting and point of contact that some patients have with the healthcare system. Understanding both the risk and opportunity for intervention in the ED is really important. For this study, we used the Vizient Clinical Data Base to look at trends in firearm injury in the pediatric population. Using the CDB allowed us to look at in a national scale across age groups, across intent, so unintentional versus intentional firearm injuries, and also layering in that community context with the VVI. That's not something that's always easy to do at a national level. And we had several key findings, and there were clear age-related patterns of ED utilization when it came to firearm injury. Adolescents accounted for the majority of those firearm injury ED visits, and they had a high number of assault-related injuries driving that volume. But there were also younger children that had firearm injuries in the ED, but those tended to be unintentional, and those were more common in that population. And that shows that the intent systematically varies by age. And it reinforces that when you look at firearm injury, you can't have a one-size-fits-all solution. It's not a single problem with a single solution. That prevention needs to be tailored by age group. Another interesting finding from this study was that firearm-related ED visits were concentrated among those high vulnerability communities. Patients from high vulnerability communities had 201% higher odds of having an ED visit for firearm injury compared to children from low vulnerability communities. That suggests firearm injury is deeply intertwined with some of the social and community level risks. It's not just random or an isolated phenomenon, that there is a really strong community tie and connection there. Beyond patient characteristics into some of the policy context, we looked at those child access prevention or CAP laws to see how that impacted the likelihood of coming to the emergency department. We found that when a child was presenting to an ED in a state that had no CAP law at all, they had 34% higher odds of coming to the ED for a firearm-related injury compared to those children in states that had any CAP law. Those laws are variable by state, but they're designed specifically to prevent access to firearms. And this finding suggests that they do play an important role in reducing firearm injury in the pediatric population. Looking more from a strategic perspective at this firearm injury, it's got important implications for healthcare systems because it can't be addressed solely through presenting at the ED, trauma preparedness, or downstream clinical care. It points toward the need for more upstream prevention-centered strategies for pediatric and all ED departments, especially those that serve a lot of high vulnerability communities and patients. It underscores that need to integrate follow-up or referral patterns and prevention resources into ED workflows, because ultimately this is a population health issue that shows up in the ED, not a problem that starts in the ED.
Alyssa, thanks for sharing. Really clear findings. Tough topic for me to just listen to, so it must have been a tough topic for you to dig into. I appreciate you doing that, and thanks for sharing. Hannah, you led a similar but different angle on a deep dive into pediatric trends in the ICU. What'd you find?
Adjacent to what Alyssa had looked at, ED visits in the CDB, another angle we wanted to look at was inpatient admissions. And so this work was presented at the American Academy of Pediatrics meeting. We looked at pediatric inpatient admissions and ICU utilization trends covering this 2018 to 2023 timeframe within the Vizient Clinical Data Base. Within that timeframe, and then even now, we know that children's hospitals and other Vizient members, hospitals in general, are under a lot more pressure in their ICU. We wanted to quantify how that's changing over time. We pulled about 2.3 million pediatric inpatient admissions across that time period. We saw that overall, the hospitalizations dipped early in the pandemic time, and then it rebounded really sharply following, especially in 2022, 2023. We saw levels that rose way above pre-pandemic. That's just looking at the inpatient admissions, but what was more striking was that ICU story. After 2020, ICU utilization became less predictable over time. The share of hospitalized kids who needed ICU care increased. It rose from about 17 to just over 18%, which is minimal, but still a strain on the system. The bigger thing was at the same time, while ICU utilization increased, ICU stays also got longer. So there was a 6% overall increase from 2018 to 2023. Specifically, that's an average, but even more so during peak season, during that flu season. We saw a lot of regional variation as well as the seasonal variation, with ICU use in the South running higher than other parts of the country. The patient mix of those who are in the ICU is really important. Kids who required ICU care tended to be younger. They were more likely to be Black. They were more likely to have Medicaid, and they were more likely to come from those higher vulnerability communities. Using the Vizient Vulnerability Index. As you'd expect, this ICU care came with longer hospital stays, much higher costs, and higher in-hospital mortality. From a strategy perspective, this highlights the value of using CDB for pediatric care. It lets us look at utilization, complexity, cost, and social risk all together. So we can think more intentionally about ICU capacity, staffing, and how to support some of those more vulnerable pediatric patients as this demand for critical care continues to grow over time.
And Rhae, I know you've looked at some ICU utilization trends as well. You've gotten into a few specific disease cases. Can you share what you found?
Yeah, absolutely. The children's hospitals that I work with on a daily basis are concerned around their ICUs today. So I've enjoyed digging into particular topics there. The first I would call out is some work we did around RSV hospitalizations back in 2023. And if you are a children's hospital leader or a parent, you might remember the Q4 2022 surge of RSV. It was a very scary time in the country where there truly was no more pediatric capacity left. Kids were not able to be transferred to the types of care that they needed. It was timely topic for the 2023 American Academy of Pediatrics National Conference and Exhibition. We looked at RSV hospitalization trends from 2019 to 2022. And there is really good RSV surveillance out there by the CDC. We weren't just aiming to look at hospitalization rates. We wanted to dive deeper into what portion of these kids are utilizing ICU. What is the hospitalization rate by children's hospitals versus your community-based pediatric program? What's going on across transfers? What are transfer rates by children's hospital and non-children's hospital? We were able to dive much deeper than what's available just in the public reporting of RSV surveillance. We found that the hospitalization rate for RSV certainly peaked above normal expected seasonal variation in 2022, and that was statistically significant. And we found that non-children's hospitals or your community-based pediatric programs experienced the greatest increases, highlighting that community burden that RSV can have, especially in really rough seasons. We found that ICU admissions increased 58% at non-children's hospitals and 30% at children's hospitals from 2019 to 2022. Tremendous demand on the ICU for a relatively common pediatric condition, but non-children's hospitals are divesting from ICU. They are not investing. They're not planning for growth in this area, highlighting what a challenging time it was and quantifying that effect. We found that the percent ICU admission rate peaked in 2021, so before the actual surge, illustrating some of the differences in acuity that existed across the time period. And all of this is related to COVID rebound volumes as well. And we found both for children's and non-children's hospital, there was a peak transfer volume in Q4 of 2022. Even those community-based pediatric programs who are normally looking to transfer high acuity children to children's hospitals were also receiving transfers from even less prepared pediatric hospitals. We saw really interesting transfer trends, and we're even able to assess the distance of transfers. We found that for pediatric viral bronchiolitis, the distance to transfer increased 11% in terms of miles during that time period. So just an incredible depth of what we were able to uncover as it relates to the RSV surge. Today, we're having a totally different type of RSV season where children's hospitals are experiencing really low RSV volumes, likely thanks to the RSV monoclonal antibody that children are accessing. Tying it back to the strategic lens, RSV and its impact on the ICU varies year to year. We've got to be referring to data and understanding the impact that these different seasons can have on our daily operations in a children's hospital.
Yeah, thanks. Some really clear findings. Hannah, it was mentioned earlier how much CDB is a valuable tool because of the ability to understand comorbidities. I understand you did something really specific looking at diabetes and mental health.
It's switching gears. I'm kind of going back to what Alyssa had looked at earlier, which is the pediatric ED visits. This analysis looked at the intersection between pediatric diabetes and mental health using emergency department data from 2018 through 2023 using the Vizient CDB. We know that from prior research, kids with diabetes are more likely to experience mental health disorders. What's been missing from that literature is a large contemporary view that helps us to understand who is most affected and what that means for their care. In this study, we polled about 24 million pediatric ED visits, and nearly 1 million of those were involving diabetes. What we found was striking. Children who presented to the ED with diabetes were older, they were more likely to be Black, and they had about 3 times the prevalence of substance use, mood, and anxiety disorders compared to kids without diabetes. And we know that the social factors mattered too. So Medicaid coverage and having a higher social vulnerability were both associated with higher odds of having diabetes. When we zoomed in then further into just those kids who had diabetes, this pattern became even clearer. So those with public insurance were significantly more likely to have a diagnosed mental health disorder, and suicide ideation or attempts were more than 10 times more common among children with both diabetes and a mental health condition. Interestingly, rural status and smaller hospitals appeared protective in our analyses, meaning they were less likely to have some of these poor mental health outcomes, but this likely reflects an underdiagnosis of these mental health conditions rather than like a lower need. So the takeaway here was that mental health can't be treated separately from diabetes care. From a strategy perspective, this shows how the CDB helps us connect these clinical conditions, social risk, and outcomes at a much larger scale.
Really good. We've covered a lot of ground already. I understand there was one other additional recent study you did, Hannah, around congenital syphilis.
This final study completes the spectrum of what the CDB can do. We focus on a rare but rapidly growing diagnosis, and this is congenital syphilis. This work looked at national inpatient data from 2019 through 2024, and we looked at both clinical outcomes and social risk. Congenital syphilis has dramatically increased in the U.S. over the past decade, despite some universal screening recommendations. We polled more than 6.7 million pediatric inpatient encounters. From that, we identified 6,500 infants with congenital syphilis, and we showed that across this time period, between 2019 and 2024, cases more than doubled across the study period, which is reflective of CDC surveillance, which is good. It shows us that what we're seeing in the CDB is what's happening nationally as well. But what stood out immediately was who was being affected by this diagnosis. So infants with congenital syphilis were far more likely to be Black, to be covered by Medicaid, and far and wide more likely to be born in highly vulnerable communities based on that Vizient Vulnerability Index. So high social vulnerability double the odds of congenital syphilis, and vulnerability specifically related to healthcare access was one of the strongest drivers of having a congenital syphilis diagnosis. The clinical impact was substantial. Newborns with congenital syphilis had much longer hospital stays. They were far more likely to require any kind of ICU care and had higher in-hospital mortality compared to infants without congenital syphilis. And then many also experience complications like prematurity, neonatal withdrawal, severe infections, even after accounting for factors over and above prematurity and maternal substance use. From a strategy perspective, this work highlights why we want to pair clinical data with social risk. And it also shows that the CDB allows us to identify these rare but devastating conditions and where they're increasing and who is the most at risk. So for members, this highlights some targeted screening, prevention efforts, resource allocation, especially in communities where these traditional screening approaches haven't been enough to slow down the trends of congenital syphilis and other rare diseases as well.
You guys have certainly been busy. Rhae, when you're talking to either pediatrics teams at bigger health systems, children's hospitals, some of these findings were confirming what we may have expected. Some are pointing us in new directions. What are you telling our members based on these new findings?
They provide a lot of support for the trends that we're talking with members every day. When members come to us asking about their ICUs, when they come to us asking how should they prepare for this big policy change, when we can point to the literature, when we can point to the data that we have in-house, it really is meaningful. That's where I try to focus, boiling all of these great research findings into actionable insights for strategy teams. We've been releasing our pediatric research at Vizient blog. It's publicly available on the SG2 website. And that's where we'll be sharing our CDB related findings, as well as those strategic imperatives that are a result of them. So please access and read up on all of our latest findings.
Hannah, Alyssa, Rhae, thanks so much for sharing all this great new research. And thanks as always for sharing your perspective with our listeners. Thanks for listening to this episode of SG2 Perspectives. Please don't hesitate to reach out to SG2 if you have questions or suggestions for future episodes.